So desmoplastic melanoma is found on high sun-exposed areas, lots of UV damage, high tumor mutational burden. So that was initial thought as to why patients may have a high response rate. We also know that there's an inflammatory state around them causing all that desmoplasia, and we think that that's contributing to the high response rate as well. The big difference between cohort A and cohort B is simply whether the disease was resectable or unresectable. So the unresectable cohort was very early stage disease or locally recurrent. The unresectable cohort was distant disease, lungs elsewhere. So they differed in the stage and location of the disease. The treatments themselves were very similar. The only difference is in the resectable cohort, they received 3 treatments and then went to surgery. In the unresectable cohort, we treated longer, same every 3-week treatments, but treated them longer because of the extent of disease. In the treatment plan, we had anticipated 2 years of treatment. We had very few people that went beyond 1 year, in part because physicians and patients realized they had no evidence of disease, no clinical evidence of disease, and didn't want to continue because of potential toxicities. We did have some that stopped because of some adverse events, but very few people went beyond that year in the cohort B. So in cohort A, the pathological complete response rate was 57%. Pretty significant after only 3 weeks of 3 cycles of treatment or 9 weeks of treatment. Very significant. When we look at the comparisons between clinical response rates and pathological response rates, they vary. So in most neoadjuvant trials, the clinical response rate tags behind the pathological response rate. The tumor dies, there's scar tissue left behind that then has to be cleared. So the clinical response rate tends to tag behind. So when we look at cohort B, those were people we followed over time, took the maximal response, giving us that overall response rate of 89%. Out of all the patients on the trial, only one, giving us that 96% response rate. We had one where we don't truly know the etiology, presented with a lung mass, didn't have it biopsied, but it's in the cohort of melanoma-specific survival. So we only have one known melanoma cause for death. Most of the other were due to other comorbidities. So 4 from cardiac disease, we had 1 from some pulmonary fibrosis, we had a patient who had had a stroke, we had a person who fell and had a CNS bleed, all the type of illnesses that you see in someone in that age group that are constantly being managed across the board. So only 1 from melanoma, both cohorts. Pretty cool. So I think the big thing here is as we move forward in melanoma treatment, we're always trying to improve the overall response rates in the cutaneous melanoma population. And many times we go from 1 drug to 2 drugs, starting to think about adding that 3rd drug. And I think what we have to do is start looking back at some of the subsets of melanoma. Separate out those groups where they don't need as aggressive treatment, they don't need all those extra toxicities. And I think this study showed us that there are some, like the desmoplastic population, that we can stop at the 1 drug, not have to give them all the extra toxicities, and that 1 drug can be pretty dramatic responses. We saw responses very early on at that 9 weeks, and they persisted now out for those 3 years. So I think that really supports us looking at melanoma in terms of different subgroups and concentrating on what we need for that particular group. At this point, we don't have strong biomarkers as such, but I think the desmoplastic melanoma diagnosis actually sort of falls into that biomarker category because it tells us how we can really slim down our therapies.